So nephritic and nephrotic syndrome. Very, very high yield topics in kidney disease. Nephrotic syndrome with the O is due to disruption of the podocyte barrier of the glomerulus. Remember the glomerulus has three different barriers: the fenestrated capillary endothelium, the glomerular basement membrane, and then the podocyte barrier. You disrupt the podocyte barrier, you're going to get a lot of protein that is able to leak from the blood vessel into the Bowman space, into the tubules. So you're going to lose a lot of protein. A lot of protein is going to go into your urine, and this is a key finding here: massive proteinuria. Okay, massive proteinuria due to disruption of that podocyte barrier is seen in nephrotic syndrome. Now, there's going to be a couple of complications that we're going to see that are all related to this disruption of the podocyte barrier. So, one, you're going to lose a bunch of albumin. Albumin is another protein, okay? And when you lose all this albumin, guess what happens to your oncotic pressure? Oncotic pressure goes down, so what happens? What would happen with decreased oncotic pressure? Well, remember, water goes from low to high oncotic pressure, low to high osmolarity. It's going to leave the vessels where it's high osmolarity out into the interstitium, and you're going to cause edema. You're going to get pitting edema in this disease. Next, you're going to lose a bunch of immunoglobulins. They're also going to be able to leak through that disrupted podocyte barrier. Okay, if you lose immunoglobulins, guess what? You're at risk for infections. Next, you lose antithrombin 3, another one you can lose. If you have decreased antithrombin 3, what happens to your coagulability? Are you going to be more likely to coagulate or less likely to make clots? You're going to be more likely to make clots because this normally prevents that. This normally puts the brakes on clot making. So now you're going to have more clot making. You're going to get clot problems. For example, DVTs, things like that. You're going to have increased risk of stroke because of clotting in the brain vessels, etc. Finally, there's hyperlipidemia and hypercholesterolemia. Okay, that one they don't really know why, but they see it. So again, nephrotic syndrome, disruption of podocyte barrier, and the key thing here is massive proteinuria. That's the key way you're going to differentiate this from nephritic syndrome, which we're going to see in a second. And you're going to see all these complications all from disruption of the podocyte barrier, mainly. So you have hypoalbuminemia. What's the complication from that? Edema. Loss of immunoglobulins leading to what? Leading to risk of infection. Loss of antithrombin 3, leading to hypercoagulable state. Finally, hyperlipidemia, hypercholesterolemia. Next is nephritic syndrome. Nephritic syndrome is different. The key problem here is inflammation and decreased filtration of the glomerulus. What was the problem in nephrotic syndrome? Disruption of the podocyte barrier. What was the problem in nephritic syndrome? Inflammation and decreased filtration of the glomerulus. Okay? And the key here is that there's going to be inflammation, makes your glomerulus a little more permeable, but it's not going to be that much more permeable. So you're going to have mild proteinuria. It's going to be less than 3.5 grams a day. This is the key difference here. This is the easiest way you can tell which one is which, whether you're dealing with a nephritic or nephrotic syndrome, is this level of protein in the urine. Okay, associated symptoms all arise due to this: inflammation and decreased filtration. So number one, decreased filtration. What is going to lead to? What is your urine output going to be? If decreased filtration, less fluid, less stuff gets into your urine, decreased urine output. What happens to your nitrogenous waste amounts in your blood? It's going to build up because you're not going to be able to filtrate it out. So it's going to build up in your blood. So you have lower urine output, build up in nitrogenous waste products, all due to poor filtration. You're also, guess what else you're going to have? You're in poor filtration of water, poor filtration of salt. So you're going to get salt retention, you're going to get edema and hypertension. Finally, we have inflammation here. Inflammation causes bleeding, and then you also have red blood cell cast. So you're going to get bleeding, which is going to present with blood in the urine, which is hematuria, and you're going to see red blood cell cast, which are like the dead red blood cells that you're going to see. Okay, so all makes sense, all arising from that inflammation and decreased filtration. And these are the two differing presentations. There's going to be nephritic syndrome, nephrotic syndrome. And there are going to be many different examples of this. We're going to cover all of them, so it's going to be a lot of stuff. But before that, I'm going to define some terms. When we see the word focal, it means that less than 50% of the glomeruli are involved in the kidney. So the kidney has many, many glomeruli. Focal means only less than half of them are involved. Diffuse thin is the opposite. It means at least more than half of the glomeruli in the kidney are involved. So throughout the kidney, over 50% of the glomeruli are involved. Proliferative means there's proliferation of cells in the glomeruli. So remember, there's mesangial cells, and they're in the mesangium. And if you have proliferative disease, there's going to be proliferation of these cells going to be a lot of them in the mesangium. Finally, membranous refers to a thickening of the glomerular basement membrane. So this basement membrane is thickened, okay? So keep these definitions in mind. They're actually going to make understanding the disease more easy. Again, you know I love understanding what the name means because it tells you a lot about the disease. So nephrotic syndrome. We're nephrotic syndrome, damage to the podocyte barrier. So there's gonna be 5 of them that we're gonna cover. First one is called minimal change disease. And this is usually just idiopathic effacement. We don't know why, but you get effacement of the foot processes. We don't know why, but eventually the damage is mediated by cytokines from T cells. So steroids actually work well here because steroids decrease a bunch of cytokines. So unlike other nephrotic syndromes, you can give steroids here. And the key thing for this disease, the key thing is going to be it's going to see it in children. If you see a kid with nephrotic syndrome, and how did you identify nephrotic syndrome? Because you most likely saw that over 3.5 milligrams of protein a day, actually 3.5 grams of protein a day in their urine. You see that in a child, you're probably going to guess it's minimal change disease, and so for treatment, you just hit him with steroids and you hope it works. Now, characteristic biopsy features. First, I want to define a few things. When we do biopsy for this problem, we can do a couple things. We can look at the biopsy on light microscopy, LM. That's like low resolution, and just how you would normally look in a microscope. Number 2, we have stuff called immunofluorescence. Okay, that means we stain it. We stain for complement or immunoglobulins and see if there's any present of that is present. That's immunofluorescence. And finally, we have electron microscopy. Electrons are tiny, so this is a super detailed microscope. You can see very closely. So on the low resolution stuff, it looks totally normal. You can't see anything. Now, if you look on the electron microscopy, when you go super high definition, super high resolution, you're going to see effacement of foot processes. And that's the whole problem in nephrotic syndrome. So this is normal. You see these nice foot processes. And then minimal change disease, you see this effacement is flattening. And so they're not working very well. Okay? So that is minimal change disease. As you can see, that's why we get the name minimal change, because on light microscopy there is minimal change. Next is focal segmental glomerulosclerosis. Okay, I want to just break down the name first. First of all, it's focal. So what does that mean? It means less than 50% of glomeruli in the kidney are affected. Segmental, it means it's not just a whole patch like 50%. It means it's segments. So segment here, segment here, segment here, segment here is affected. And then glomerulosclerosis means there's sclerosis of the glomerulus. So it's like scarring, doesn't work very well. And that's how you get damage to the podocytes. Idiopathic cause, we don't know why. Associations. So this, I'm going to read a bunch to you, but I really want you to focus on the African American, okay? I'm going to be a little racist here, but it's also it's supported by evidence, or by the just prevalence rates. But African Americans and Hispanics get this most. But the reason I'm going to be a little racist is I remember that heroin use, HIV, and sickle cell disease are also associated with this, because you see these more often in African Americans. You see a lot of heroin use, a lot of HIV, and sickle cell, all in African Americans. So honestly, you just have to remember African Americans. It makes your life a lot easier. And you remember that they're also more likely to use heroin, HIV, and sickle cell disease. Next, on biopsy, kind of easy. You're going to see segmental sclerosis and hyalinosis. So you already know from the name, segmental sclerosis and hyalinosis on light microscopy. So I want to add that you can also see effacement of foot processes here, like you would in the minimal change disease. Next is membranous nephropathy. First of all, this is usually idiopathic, and there's a primary idiopathic or a secondary. So primary idiopathic just happens. We don't know why, but we see an association with antibodies to the phospholipase A2 receptor. Antibodies to phospholipase A2 is seen in membranous nephropathy. Now that's the primary idiopathic cause. We also see secondary causes which are associated with things. So you can see it often with hepatitis B or C, solid tumors, SLE, or drugs. Okay. Now, I'm going to focus on the name membranous again. What do we say membranous means? Membranous means thickening of the basement membrane. So that's what you're going to see on light microscopy. You're going to see diffuse capillary and GBM thickening. Okay, membranous nephropathy already tells you all that. And there's no increase in cellularity. Okay, remember that increase in cellularity. What was that? What was that word that we would use for that? Remember that word would be proliferative. Well, we don't see proliferative in his name, so there's no increase in cellularity in this disease. The other characteristic feature here is a spike in dome appearance. Spike in dome appearance of subendothelial deposits on electron microscope. Okay. Spike in dome appearance, keyword for membranous nephropathy. Next is amyloidosis. Amyloidosis is a systemic disease. You get deposition of amyloid in a bunch of different organs, and in this case, in nephrotic syndrome, it's due to deposition in the mesangium of the kidneys. Okay. Now, what about amyloid do you remember about? Was there any staining that you remember for amyloid? You see that a lot. So the staining here was that you stain with Congo red, and you're going to get apple green birefringence. Okay. Apple green birefringence automatically tells you you're dealing with amyloid here, so it's easy peasy. Finally, we have diabetic glomerular nephropathy. This is due to due to hyperglycemia causing problems. So the hyperglycemia is going to cause that non-enzymatic glycosylation of the glomerular protein. So it's glycosylation just due to a bunch of too much glucose in the blood. There's no enzymes involved. So hence it's the non-enzymatic glycosylation of glomerular proteins. And this will lead to mesangial expansion, glomerular basement membrane thickening, and increased permeability of the glomerulus. Okay. Increased permeability of the glomerulus due to this hyperglycemia. Now your efferent arteriole is affected more than the afferent. So the leaving side is affected more than the entering side. Basically there's more scarring here on this leaving side. So you're going to have increased pressure. Remember that pressure goes up in this glomerulus, and that's going to cause damage. Extra pressure causes damage to your glomerulus. Okay, the characteristic feature here, and this is a gimme if you ever see this, is eosinophilic nodular glomerulosclerosis. So it's sclerosis in a nodular circular shape, and you can also call this Chemisteel-Wilson nodule. If you ever see this picture right here, it's 100% diabetic glomerular nephropathy. Okay. And then you see eosinophils, you see it's glomerular sclerosis, it's nodular. Just basically recognize that picture and know that's diabetic glomerular nephropathy. So that's it for nephrotic syndromes. This is the one with podocyte damage and massive proteinuria. There's minimal changes as you see in children, and this one looks normal on light microscope. You see effacement of foot processes on electron microscope. Focal segmental glomerulosclerosis, aka FSGS. Really just pay attention to that name, it tells you a lot. And remember that African Americans get it, and the rest of the risk factors are a lot easier to remember. And the name shows you biopsy features, segmental sclerosis, and hyalinosis. Membranous nephropathy is a couple things to memorize. Antibodies to phospholipase A2, a little bit of associations, those are lower yield. And then remember that spike in dome appearance of the subendothelial deposits. Amyloidosis, easy, you should already know this, apple green birefringence on Congo red staining. Diabetic glomerular nephropathy, remember you have the kidney damage due to hyperglycemia and non-enzymatic glycosylation. And then you're going to see these Chemisteel-Wilson nodules. Recognize that picture. Next, nephritic syndrome. Okay, what was the problem in nephritic syndrome? Remember the problem was inflammation and damage and leading to poor filtration. Okay, and you're going to see mild proteinuria. That's the big difference. Mild proteinuria versus massive proteinuria. Alright, so there's many of these. There's another 6 of these that we have to recognize. So let's get into it. Acute post-strep glomerulonephritis. The problem here, okay, first of all, this is post-strep. So this happens after a streptococcal infection. What happens is you're going to develop antibodies against the strep antigens. Unfortunately, these antibodies are not only going to act on the strep antigens, they're also going to act on the glomerular basement membrane, and they're going to cause damage and inflammation, and they're also going to decrease filtration. So the identifying feature here is that these occur 2 to 3 weeks after streptococcal infection, okay? And the thing is, remember that these antibodies take time to develop. So about 2 to 3 weeks later, finally your antibody develops. And then 2 to 3 weeks after the initial infection, it could be either a strep skin infection or a strep throat or strep infection of the pharynx in children. So you're going to see the development of this kidney injury. You see that what were the signs of nephritic syndrome? Do you remember that? Remember, it was things like red hematuria, red blood cell cast, and you can also see that poor filtration leading to edema leading to buildup of renal weight of the waste products. Again, 2 to 3 weeks after streptococcal infection. And the reason why I emphasize this so much, 2 to 3 weeks, is because in another nephritic syndrome I'm going to talk about, IgA nephropathy, it's going to occur at the same time or within 5 days of a respiratory infection. So you're gonna get a story of a kid who had recently had an infection. You need to figure out which nephritic syndrome it is because they both present as nephritic syndrome, and so that timing is going to be super important for you to figure it out. So on biopsy, there's going to be a lot of stuff going on, okay? 1. Enlarged and hypercellular glomeruli. 2. Starry sky appearance on immunofluorescence. Remember, immunofluorescence looks at complement and antibodies. We see here that we had antibodies mediating this problem, so that's why you're going to see antibodies on immunofluorescence, okay? And finally, this one's super characteristic, subepithelial humps. You see subepithelial humps under this epithelium. That's what it means, subepithelial humps. You know it's acute post-strep glomerulonephritis. Okay, rapidly progressive crescenteric glomerulonephritis, RPGN. This is a severe autoimmune injury of the glomerular basement membrane. Okay, severe autoimmune injury. Okay, you can see this in diseases such as Goodpasture syndrome or in pauciimmune vasculitis, so like Wegener syndrome. Okay. One thing about these two diseases, these are the only two diseases that you will ever see that cause hemoptysis and hematuria. Okay, these both act at the lung and the kidney, so they're going to cause bleeding in the lung and at the kidney. So you're going to get hemoptysis, which is coughing up blood, and hematuria. So if you see hemoptysis and hematuria together, you only have two options. You have Goodpasture syndrome and Wegener syndrome. Okay, and both of these can cause something called a rapidly progressive glomerulonephritis. And the very key thing here is this is very rapid progression to renal failure, okay? These guys get renal failure in a few weeks to a month. That's why, hence the name rapidly progressive. Now, the other part of the name, crescenteric, comes from the biopsy feature of a crescent-shaped glomerulus. So the glomerulus looks kind of like this. That's a crescent, okay? And that's because these crescents contain fibrinogen and macrophages from all that inflammation. Okay, so crescent-shaped glomerulonephritis glomeruli tells you it's RPGN. Now, if you do immunofluorescence, what you're going to see is, remember, immunofluorescence looks for antibodies and complement. Goodpasture syndrome is resulting from GBM antibodies, so antibodies against the glomerular basement membrane. So you're going to have a linear. So there's going to be antibodies here, 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 hitting all that basement membrane. So it's going to light up like a line. It's going to be complete linear immunofluorescence. Pauciimmune vasculitis, remember those? Those don't light up for antibodies. They're pauciimmune, so they're going to be negative immunofluorescence. So that's how you can tell the difference. One has a linear immunofluorescence, one has negative immunofluorescence. You should already know this based on the pauciimmune, which is Wegener's, versus a Goodpasture syndrome. Next is diffuse proliferative glomerulonephritis. Okay, this is due to immune complex deposition. It's usually related to SLE. Remember, SLE was also seen in membranous nephropathy, but SLE is also related to this diffuse proliferative glomerulonephritis. And the thing that we see here is that we see wire looping of capillaries. Okay, wire looping of capillaries on light microscopy. So lupus, SLE, lupus has the wire loops. Now I just want to add at this point that I keep talking about these things like wire looping, crescent-shaped glomeruli, and not subepithelial humps, and even in nephrotic syndrome. I keep telling you about all these things, so I'm not showing any pictures. I would recommend just check the link below. There's a nice website showing a bunch of pictures, or just Google it yourself. I couldn't find any pictures for you that were not copyrighted, so please do it yourself. Look at all those pictures, be able to recognize them, because you might definitely get some pictures on the test. Okay, next is IgA nephropathy, aka Berger disease, and this is not to be confused with Berger's disease. Remember what that was? Remember that was the one with people who smoke a lot and they get the Renal's phenomenon. They get that auto amputation of their digits. That was a small vessel vasculitis. So this is not that. This is different. This is an IgA nephropathy. So results from IgA complex deposition in the glomeruli, especially the mesangium. Okay, so how does this present? This usually presents with hematuria concurrently with a respiratory or GI infection. Okay, because these respiratory and GI infections will lead to IgA secretion. IgAs is an antibody that we secrete by our mucosal lining. So we're going to secrete this IgA in response to a respiratory GI infection, and then this IgA is going to complex with antigens, so infectious antigens, and then they're going to deposit in this glomeruli. That's what's going to cause problems. Okay, so what are we going to see on biopsy? What are we going to see on immunofluorescence? Remember what immunofluorescence is looking for antibodies. We're going to see mesangial IgA antibody deposits. Okay, we should already know that based on the cause of injury section. And you're going to see mesangial hypercellularity on the light microscopy, again, because we have deposition and then mesangium. You're going to irritate them and cause them to grow more. Okay, next is the Alport syndrome. Alport syndrome is due to defective type 4 collagen. Okay, type 4 collagen is involved in the basement membrane structure. So if you have defection there, you're going to get thinning and splitting of the basement membrane. Okay, it has weak structure and it's get thinning and splitting. Now there's couple very key identifying features. So again, we already know this glomerulonephritis. What you're also going to see is eye problems and hearing problems, because you're going to need that type 4 collagen in both of those areas. And if you have defect there, you're going to have eye problems and hearing problems. So key description here is the laminated, aka basket weave appearance of the GBM. Again, it's due to our defect in the GBM and the type 4 collagen, and causes this appearance. Look up the picture again, see what I'm talking about. Finally, last but not least, membranous proliferative glomerulonephritis. So from the name, you can tell this membranous thickening, your proliferation of cells in the glomerulonephritis. There's two types. Type 1 is immunoglobulin mediated. This is associated with hepatitis B, so you get antibodies that end up damaging the glomerulus. Type 2 is a complement-mediated damage of the glomerulus, and it's associated with C3 nephritic factor. So I just want to explain what the heck is a C3 nephritic factor. C3 nephritic factor stabilizes a C3 convertase. So C3 convertase activates complement. So if you stabilize this activation, you get overactivation of complement. Okay? And what you're actually going to see is you're going to see decreased C3 levels. I just told you we activate complement. Why do we have decreased C3 levels? Because you overactivated it, so you used up all the C3, so you have decreased C3 levels. So C3 nephritic factor leading to overactivation and complement and depletion of your C3. Okay, now what is our biopsy features? You're going to see a tram track appearance due to splitting of the glomerular basement membrane, and then type 1 has some subendothelial deposits, type 2 is intramembranous deposits. It's a little lower yield, but that's how you can tell the difference. Okay, I just want to do another big overview. I just told you a massive amount of information, but I hope a lot of things make sense to you, okay? Acute post-strep glomerulonephritis, you look at the name, you already know it's post-strep, then you can remember it's due to antibodies cross-reacting. Remember these antibodies take a while to make, so it's 2 to 3 weeks. That's the way you differentiate this one versus the IgA nephropathy. 2 to 3 weeks here. IgA nephropathy is concurrently or only a few days after a respiratory infection. The key thing here is I'm going to erase everything. Key thing here is subepithelial humps. You should know that the immunofluorescence, if they asked you, you would get some antibodies and some C3 deposition, because this is mediated by antibodies. Okay. Rapidly progressive crescenteric glomerulonephritis, easy to remember, name tells you a lot. Rapidly progressive crescents. So crescentic glomerulonephritis, rapid progression to renal failure, is associated with either Goodpasture syndrome or Wegener's. Okay, the only two that are ever going to cause you hemoptysis and hematuria. And then the immunofluorescence is going to help you differentiate. You already know. So Goodpasture syndrome mediated by antibodies against the basement membrane. The Wegener's will not show anything because it's posse immune. Diffuse proliferative glomerulonephritis associated with SLE, and that's going to tell you its biopsy features. Remember, lupus has the wire loops. Okay, so that's easy to remember. IgA, easy to remember because you have IgA problems related to the respiratory GI infection, and then so immunofluorescence is going to be easy. Alport syndrome, again, easy. Defective type 4 collagen, that's the only thing you have to remember. It's going to cause weakness of your basement membrane, and then thus you're going to have problems in the basement membrane, problems in the eye and the ears. Membranous proliferative glomerulonephritis is one a little harder to remember. Just read it, memorize it. Okay. The other ones that are harder to remember is if you go all the way back to nephrotic syndrome. Um, let's see, what was it? So diabetics easy to remember, just that really characteristic thing right here. Amyloid super easy to remember. This one's harder to remember, spike and dome. So just try to memorize that, and then the rest are pretty easy. So that's it for nephritic and nephrotic syndrome. I know this is you're gonna have to do some brute force memorization, but I hope I can point out a lot of the similarities and how the biopsy features or identifying features can relate to causing injury. Okay, so make sure you know all of these. You're gonna get tested on these. You have to be able to differentiate which is which.